Dr. Schwarzkopf. So nice to see you. Nice to meet you.
It's a pleasure.
I'm Alejandro Espero from Malaga, Spain, and I wanted you to introduce first.
I'm Ran Schwarzkopf. I'm a professor of orthopedic surgery from NYU Langone Orthopedic Hospital in New York City.
Okay, perfect. So we wanted to ask you some questions about your practice. What makes a hip revision especially difficult for you and especially challenging?
So I think hip revision has been evolving over the years because the reasons patients come for a hip revision have been changing. So I think the newer challenges we see now is the type of implants that are used. The new triple taper collared stems that are placed now in primary hips are a little bit more difficult to remove than the single wedge tapered stems that have been used for the past 20 years. So now when we encounter revisions, we have new tools, new osteotomes, or we have to do actually more osteotomies to remove those stems. So it kind of made a full circle and brought us back to the implants of the 90s, the fully coated stems that were much more difficult to remove. And then we had a period of time that we had the single taper, which was much easier in the operating room to get them out. And now we're back to a little bit more difficult implants to remove if we have to during revisions.
Okay, and what do you think are the tools that you will be using in the future or the near future? What are the new changes that are you trying to introduce into your practice?
So I think robotics, as you know, has been growing tremendously, especially in the United States. Robotics and navigation are starting to be used in every primary case, and in the next 5 years probably be widespread. And now the robotics are coming into the revision. So that will allow more accurate screw placement, more accurate implant, and more control of leg length and offset beyond what we're able to do today.
Okay. And what else do you think about the dual mobility cups? Because in Europe and I think that also in France, there are many surgeons that have used them for a long time, and they use it in almost every patient. What do you think about them?
So I think dual mobility has to be divided into two types of cups, and it's a misconception just to call everything dual mobility. In Europe, in France, and in Spain, they've used a monoblock dual mobility. That's a cup that has an anatomical size head, similar to hip resurfacing, but it does not have the ability usually to put screw fixation. And sometimes the handles and the control of the position of the cup is not as accurate. In the United States, the big monoblock cups have not been used in the past. They were not common, they were not available. So we got used to using the modular dual mobility, where you put a regular cup if you want screws or without, and then you have a liner that allows the dual mobility. That size is smaller than the size of the monoblock. So we're comparing two things that are not exactly the same. There was a surge in use of dual mobility in the United States. It went down a little bit. I think now we understand that it's the overall size of the head. So if you don't use a monoblock cup and you're using a modular, sometimes using a 44 or a 40 head, it gives you almost the same size as a modular dual mobility. So that's why it's not as much used in the United States as in Europe. And we look for the accuracy of the position of the cup with robotics and with navigation. So we sometimes feel we don't need to go to those huge heads when you put a cup that's not exactly accurate in its position.
Okay, so thank you very much. It's been great to have you here. So thank you very much for your participation.
It's a pleasure. It's a great congress. Thank you.